All right, let's jump right in. Today, we're tackling one of the biggest questions in managing atrial fibrillation. Do we control the rate or do we control the rhythm? For us as pharmacists, getting this right is absolutely fundamental to great patient care.
So imagine this. A patient presents with new onset AFib. What do you do? This is the crossroads. It's the first big strategic decision that's going to dictate their entire treatment plan. We're not just picking a drug. We're choosing a whole philosophy of care for that specific person.
So here's how we're going to break it all down. First, we'll define the choice itself. Then, we'll explore the case for rhythm control, when and why we go that route. We'll do the same for rate control. Then we'll get into our turf, the pharmacist's toolkit. And finally, we'll cover the one thing that connects it all, preventing strokes. Okay, first things first. Let's get really clear on what we're even talking about. What's the actual goal of a rate control strategy versus a rhythm control strategy? Because they are fundamentally different approaches. Think of it like this. Rate control is basically a strategy of acceptance. We're saying, okay, the AFib is here to stay, but we're not going to let that fast, chaotic rate damage the ventricle. We manage the consequences. Rhythm control, on the other hand, is a strategy of restoration. The goal here is to actively kick the heart back into a normal sinus rhythm and, just as importantly, keep it there. So who are the prime candidates for rhythm control? Which patient walks in the door and makes you think, you know what, just slowing down the heart isn't going to cut it for this person? Let's look at those profiles.
We really lean into rhythm control when a patient's quality of life is just tanking. They're feeling every palpitation, they're short of breath, and just feel awful. It's also a big one for younger patients because we want to prevent years and years of the heart remodeling itself, which can make AFib permanent down the line. And of course, in heart failure, getting that normal atrial kickback can make a world of difference for their cardiac output.
And this right here, this is a game changer. It points to a huge shift in our thinking thanks to massive trials like EAST-AFNET 4. What they found was that in high-risk patients, starting rhythm control early, like within the first year of diagnosis, actually led to better outcomes. We're talking fewer strokes and cardiovascular deaths. So timing, it turns out, is everything.
But look, going all in on rhythm control isn't the right move for everybody. So let's flip the coin. When is rate control the safer, more practical, and honestly, the better strategy?
And this number, it says a lot. Age is a huge factor in this decision. For older folks, especially those over 80, the potential risks that come with antiarrhythmic drugs and procedures can really start to outweigh the benefits of being in perfect sinus rhythm.
So here's your classic rate control candidate. Picture this. An older person, maybe their AFib was found totally by accident on a routine checkup, and they feel completely fine. For them, or for someone who's had AFib for years and failed rhythm control before, a simple, safe rate control plan is often the most sensible way to go.
Okay, so the strategy's been chosen. Now we get to our part. As pharmacists, we've got to know the tools inside and out. So let's open up the toolkit and see what we're working with, starting with rate control.
For rate control, our workhorses are the beta blockers, metoprolol, carvedilol. They're first line for a reason. Non-dihydropyridine calcium channel blockers like diltiazem are fantastic too, but you have to remember that big, bold, underlined warning. Be super cautious in heart failure with reduced ejection fraction. And digoxin, it has its place, especially for sedentary patients, but you have to counsel them that it's not going to do much for their heart rate once they get up and start moving around.
Now, the rhythm control path, it's definitely more of an escalation pathway. It often kicks off with cardioversion, a reset for the heart. But the real challenge isn't getting them back into rhythm, it's keeping them there. That's where maintenance antiarrhythmics come in. If those don't work, then we start moving up the ladder to things like catheter ablation.
Okay, and this is absolutely critical for us as pharmacists to know cold. The number one rule is you have to match the drug to the heart structure. If the heart is structurally normal, agents like flecainide are a great choice. But, and this is a big but, if that patient has coronary artery disease or heart failure, those drugs are a no-go. That's when we have to pivot to drugs like amiodarone or dofetilide, and we have to be all over the complex monitoring and side effects that come with them.
So, we've talked about two totally different paths, right? Rate versus rhythm. But no matter which road you go down, they both lead to the exact same non-negotiable destination.
Listen, if you only take one thing away from this whole explainer, please let it be this. Restoring sinus rhythm does not eliminate stroke risk. It doesn't. A patient can flip back into AFib without anyone knowing. A rhythm control strategy is never, ever a substitute for proper anticoagulation based on their stroke risk score. And let's be real, when we say anticoagulation for AFib today, we're almost always talking about the DOACs. The guidelines couldn't be clearer. For most patients with non-valvular AFib, these are the preferred agents over warfarin. And this table right here, this is our bread and butter, isn't it? The convenience of DOACs is just a massive win for patients. No INRs, fewer interactions, they just work. But we always have to remember that key exception, patients with mechanical heart valves. For them, warfarin is still the undisputed king, and that's a critical safety check every single time.
So what does the future hold? With ablation getting safer and more effective, and trials showing benefits to early rhythm control, you have to wonder, are we heading toward a future where rhythm control first becomes the default strategy for almost everyone? It's a fascinating question, and it's what makes this one of the most exciting areas in cardiology right now. Thanks so much for joining me.